Okay, thank you very much. I would like to thank Alicia and Sakura for giving me the opportunity to be with you today. I just wanted to very quickly tell you about these two individuals. Rosemary Wright was an individual that I worked with here at the Medical University. Rosemary was diagnosed with stage 4 breast cancer, and if you're not familiar with that terminology, you will be before we finish today's presentation. She came to work every day, and I did not know that Rosemary was battling this horrible disease during the time that I worked with her. I just learned one morning that we had lost her, and that's when her story became apparent to me. She was a hero in the sense that she came to work every day and she was very private, did not let anyone know that she was battling this terrible disease. Peggy is a hero to everyone in histotechnology. You may know her name. We lost her earlier this year, and I'm not sure histotechnology will be quite the same without her. So I do want to dedicate this presentation to these two individuals. Breast cancer is, in my opinion, a very horrible disease, one that affected me very early in my career, and I think that is what stimulated my interest in the topic. Today I'm going to try to cover what are going to be the high points, because this is a very complex topic, one that would be very difficult to cover in the time that we have together today. But I am going to touch on the epidemiology and the prevalence of breast cancer in the population. I'll talk a little bit about the different forms of breast cancer, and of course you're going to have an interest in the prognostic markers and the work that we do in the histology laboratory. And how do we use those markers? How is that used by oncologists? How is recurrence predicted? And I want to talk somewhat about the regulatory requirements that we now have had imposed on us in the clinical laboratories that are working on breast samples. Okay, I didn't advance it. There we go. Okay, I want to talk just a brief word about cancer in general. If you're anything like me, I think many of us have somewhere buried deep in our consciousness thoughts that we wonder if, especially with the work that we do each day, whether we ourselves will at some point become a cancer, a person that has cancer who's battling cancer. According to the latest data from Cancer Facts and Figures, which you can find online, 1.6 million Americans will be diagnosed with some form of cancer this year, and a little over 500,000 will die from some form of cancer. And so that's the equivalent of 3 jumbo jets crashing every single day. It's a horrible statistic, and yet a very sobering one. And I think that is what the important take-home message, I think, is that through the many decades of my career, we have found that cancer still is a very important part of healthcare in this country, and one that preoccupies the thoughts of many of us. Now, they tell us that about 1/3 of cancer deaths are related to tobacco use, and another 1/3 related to nutrition and physical activity and obesity. So it gives the impression that we have some control over our destiny, but the truth is that for some cancers, we really don't know very much about how to prevent those illnesses. Now, breast cancer, well, let me show you this slide first. You can see that among women, breast cancer is the most prevalent cancer, and of course in men it's prostate. What intrigues me about this is I don't know what it is about glandular tissue that makes that tissue type so susceptible to forming malignancies. You can see other glandular type organs in the list that I have on the screen. So let's talk a bit about who gets breast cancer. First, I do want you to be aware that oncologists today believe that the term breast cancer actually refers to any as 10 different diseases, all affecting the breast. And that's a pretty staggering statement to make, but it's one that reflects the fact that there are not only different types that we'll talk a little bit about today, but also the way that those tumors behave and respond to treatment. So they've been categorized as somewhat different illnesses, perhaps that may be due to different causes. What is sobering to me is that even in 2014, we cannot tell you what causes breast cancer. And if we don't know what causes it, then we really cannot tell you how to prevent it. The most obvious risk for breast cancer, of course, is being female. Now, men, of course, do get the disease, but it's about 100 times more prevalent in women. Another risk factor is being over the age of 45. So as a woman ages, her risk for this illness increases. If you have a close relative who's had this disease, then you have a higher risk of developing breast cancer sometime in your lifetime. What is important, though, is that up to 80% of women who have breast cancer or who will get it will have no family history of that illness. You have heard of the breast cancer genes 1 and 2, and for patients who have family members who have suffered from breast cancer, we will test those patients to see if this gene is present. If it is, they have an 80% risk of getting that breast cancer in their lifetime. And so the testing is done primarily to enable those patients to make important therapeutic decisions early before breast cancer develops. So who gets breast cancer? Well, the probability of getting breast cancer in a woman's lifetime is 1 in 8. In 2014. And what's interesting to me is that back in the 1960s, the risk was only 1 in 14. So the risk has certainly increased. And if we have the time to speculate, we imagine how life, at least in this country, has changed over those many years. White women have a higher incidence of breast cancer than African American women, starting at about age 45. But unfortunately, African American women have a higher mortality. So when African American women have breast cancer, it tends to be more aggressive. The median age for those with breast cancer is 61, which means that 50% of women with breast cancer are younger than 61. I'm going to show you 2 or 3 charts from the American Cancer Society, and even though the dates are not current, this is the most current data that is published by the American Cancer Society. So this gives you an opportunity to see what the incident rate is for different ethnic groups. And you can see that we started collecting this data in 1975, which is around the time when tumor registries were developed. And so virtually everything that we know about cancer in general is derived from statistical data from having compiled all this information across the population. So you can see in the top part of the graph that white women do have a higher incidence of breast cancer that slightly increases over time as the years have progressed. It's also noteworthy, I think, that we have a population, including the Native Americans, Hispanic females, and Asian Americans, who have a significantly lower incidence of breast cancer. And if we had the time, we might speculate as to what that might be due to. This presentation is a condensed form of a presentation, a much longer presentation that I've given for some state organizations and also for the NSH. And in that presentation, I've speculated that dietary habits may well have contributed to the lower incidence in those populations. Here you can see the incidence graphed against mortality. And in the bottom portion of the graph, you can see that the pink line at the bottom is the mortality for African American women, and you can see that that's somewhat higher than for Caucasian women. These charts here, the table on the right, shows you that as a woman ages, her incidence or her probability of developing breast cancer can increase significantly. And the death rate for breast cancer in women has decreased since 1990, largely due to improved therapeutic regimens that have become available. So there's some silver lining, even though incidence has not gone down and has actually gone up. We seem to have better tools for at least controlling the progression of the disease. So what factors influence breast cancer survival? Well, we've known for many years that the stage of the illness at the time of diagnosis has an important impact on a patient's prognosis and on their ability to beat their disease. So a 5-year survival is 98% for women that have localized disease. So that would mean in situ or cancer that has not progressed to the axillary lymph nodes. Regional disease would imply axillary lymph node involvement. And of course, if there's a metastatic spread beyond the lymph nodes, you can see that the survival rate is very low. It's 23%. So, for example, my friend Rosemary, who was diagnosed with stage 4 breast cancer, her opportunity to survive her illness was very, very low. Likewise, you can see the 5-year survival for the tumor size is also relevant. And of course, we stress in the media early detection. And so women have been encouraged to engage in self-breast exam. And of course, we encourage women to have mammograms, which I'm going to talk about in just a moment. So 5-year survival is 95% for tumors less than 2 centimeters in diameter. And as you can see, as the size of the primary lesion increases, the 5-year survival rate decreases. Also, we find that the age at initial diagnosis is relevant to survival. The 5-year survival is slightly lower among women who are diagnosed before the age of 40. So we find that lesions in very young women tend to be significantly more aggressive than for women over the age of 40. So can breast cancer be prevented? Well, unfortunately, there does not appear to be a way to prevent breast cancer, but I think in large measure that's because we really do not understand what causes this spectrum of pathology. But your best preventive health strategy is to reduce known risk factors, which include weight gain and obesity. And the important reason for that is because adipose tissue makes estrogen, and we do know that the estrogen status of a patient can influence the development of breast cancer. We also encourage women to engage in regular physical activity and to minimize their alcohol intake. We also know that women who've breastfed children have had some protective effect that's associated with lactation and breastfeeding. So while we may not understand the significance of that, that is an observation that statistically is important. I understand that Sakura will make this presentation available to you. You may not have time to read the table on the left, but you can certainly come back. So this is just to show you the anatomy of the female breast. And what's relevant to us is going to be the glandular tissue and the ducts leading from the glands to the nipple, because that is the area where the pathology is likely to arise. The size and shape of the breast is determined largely by the adipose tissue in the breast. And all women, regardless of breast size, have a similar complement of the number of glands. So I've indicated here 15 to 20 lobes are typical. And the glandular cells and the duct are referred to as the terminal duct lobular unit. So if you read anything in the literature, you will see that term. What I also want to point out is that in the upper right image on your screen, you can see that there are a number of lymph nodes in the vicinity of the breast. And these are important because if a woman presents with a primary lesion, one of the first things we need to understand is whether or not she has lymph node involvement. And we typically can access lymph nodes in the axillary region simply because they're more accessible than many of the other lymph nodes that you see in that illustration. The image on the left gives you an idea of the venous and arterial blood supply that nourishes the breast. And these are areas where, of course, if a woman has a more advanced lesion, there's opportunity for metastatic spread. The degree of glandular tissue is affected by the hormonal environment of the individual. Women will know that during their monthly menstrual cycle that they are conscious of changes in their breast, and some may even report at certain times tenderness in the breast. We do know that a woman's breasts will change during pregnancy. And we also know that breast tissue or glandular tissue actually diminishes after menopause. So these are changes that are largely affected by the hormonal environment. Now this observation is important because if we know that normal glandular tissue is affected by hormones like estrogen, it's reasonable to presume that malignant cells deriving from this glandular tissue may also be influenced by the hormonal environment. So this is an H&E image just giving you a illustration of a normal breast tissue showing both ducts in the upper right corner and the glandular lobules. And of course, you can see the clear areas in the image are where the adipose tissue formerly resided prior to tissue processing on your processor. And one of the things that I want to point out is that you can see that the ducts are fairly uniform in size in this image, even though the shape of them may be they aren't necessarily round, and some of that has to do with the way that the tissue was embedded in the paraffin block and whether the tissue was cut tangentially. But what's noteworthy is that a duct is normally lined with 1 or 2 cell layers of epithelial cells. So in the normal duct, that's what one would expect to see. This is an image of a postmenopausal breast, and you can see that there's considerably less glandular tissue after menopause. So the ducts and the glands are lined, as I said, by 2 layers of epithelium, which in turn is supported by basement membrane. Most diseases that arise in the breast affect either the ducts or the glands and arise actually in those epithelial cells that line those branching structures. I thought you might have an interest in just a microscopic image of fibroadenoma, which is a benign lesion, often more common in young women. So if a young woman finds a lump in her breast, of course that's always a cause for alarm, but most often it turns out to be a fibroadenoma, as you can see in the upper left image. Papillary lesions, and you may be familiar with that term, have this very distinctive appearance that you see in the lower right image. And these are often associated with fibrocystic change. Many women have been told that they have fibrocystic breasts, and those who have that are familiar with the symptoms associated with that. Also, fibroadenomas can have calcifications, and women who do have mammograms become concerned if calcifications are found in their mammogram. However, in order for calcifications to be a concern, they need to take on a very specific appearance. So I wanted you to be aware that even benign lesions can be calcified. All right, so the terminal duct lobular unit, and once again, the image in the lower left is normal breast tissue. The illustration in the upper right is to show you how a normal duct can have a uniform layer of epithelial cells, but one can get hyperplasia, which would be the second image down, where the number of cells now has gone beyond what we would consider normal, and if that continues to grow, then it can become a carcinoma in situ, and if it goes beyond the duct, then of course the cells in the illustration on the right, you can see that there are malignant cells that have made their way into the lymphatic system and are now in that lymph node that you see in that drawing. And of course, once again, the lymph nodes surrounding the breast in the chest are in the shadow of that background illustration. So now this is an image of lobular aplasia, not necessarily malignancy, but you can see how the architecture is significantly different from what I've shown you previously in the normal slides. So neoplasia really simply represents an increase in the number of cells, whether it be in the duct or in the lobule. And of course, if that continues to progress, one can go from hyperplasia to carcinoma in situ or infiltrating or invasive carcinoma. So the illustration on the left is showing you the stages of breast cancer. And I told you that my friend Rosemary was diagnosed as stage 4. So you can see in that large duct how stage 0 and stage 1 are very, very small lesions. And in fact, for women who engage in self-breast exam, those would be very difficult, if not impossible, to palpate. But once one gets to stage 2 and stage 3, especially stage 3 and stage 4, those can be very palpable lesions. And of course, as you can see, as the size of the lesion progresses, the lesion goes beyond the duct, outside the duct wall, into the serosa and the muscular layers, and then can, certainly at stage 4, metastasize into the bloodstream. And the image on the right shows you the organs that breast cancer can metastasize to. And in addition to lung and liver, breast cancer can metastasize certainly to bone and sometimes to brain. So the stage, of course, is very important, and one of the first things that the pathologist needs to do when we receive a breast lesion in the laboratory. This is a microscopic image of breast cancer in the pelvis. In the right side of the image, you can see hints of lesions within that bone that are, in fact, metastatic breast cancer. Okay, so this is an image now of atypical ductal hyperplasia. And in this image, if you look around, you'll see some ducts that appear relatively normal, others that clearly are hyperplastic. Some have more than 2 layers. Some, it's hard to even see that there's a patent lumen in that duct because it's completely overrun with cells. Yet each of the ducts is relatively intact. You don't see that the growth has gone beyond the duct. Atypical ductal hyperplasia, if a woman were to have a needle core biopsy, this would be a concern because although it's a benign condition, we can't be certain that the oncologist did not miss a lesion with the needle. And so therefore a woman who gets this diagnosis is going to go back for a lumpectomy because they want to rule out the possibility of a cancer lurking within that patient. Now, unfortunately, there are often no symptoms associated with breast cancer, but there may be other signs that something is wrong. So, of course, if a woman, if she feels a lump in her breast, of course, that's going to cause some alarm, and that will prompt her to contact her physician. But any changes in breast size or shape, any swelling, especially in the axillary region, any changes in the nipple or any discharge are causes for concern, and those are reasons to contact your physician. I did not mention, and I do want to be sure I include, that in addition to self-breast exam, the American Cancer Society recommends annual clinical breast exam. And the distinction there is that they're asking that you have a physician examine your breasts at least once a year. As you can imagine, women who are acutely aware of their breasts, especially if they have cystic breasts, can become alarmed for changes that they may have sensed or felt that may or may not be clinically relevant. And that's the reason why the American Cancer Society wants every woman to be seen at least once a year for a clinical breast exam. Histologically, breast cancers generally belong to one of 2 groups, and those would be either ductal carcinomas or lobular. And I do want to just talk a little bit about those in general. So ductal carcinomas constitute 65 to 80% of all breast cancer cases. And you may be familiar with the term DCIS. The acronym means ductal carcinoma in situ. And one can also have invasive ductal carcinoma. Lobular, meaning arising in those lobules or glandular cells, constitutes about 15% of all breast cancers. These can occur at any age, but they're most common between the ages of 45 and 55. What's unique is that they're most likely to occur in both breasts. So lobular carcinoma diagnosed in one breast is likely to prompt the physician to look more closely at the other breast because there may be a mirror lesion in that breast. The problem with lobular carcinoma is that it's very difficult to see on mammogram. So mammography is not a very effective tool for identifying lobular carcinomas. And much like the ductal carcinoma, one can have lobular carcinoma in situ or infiltrating or invasive lobular carcinoma. So here's an image of ductal carcinoma in situ. And one of the things that's kind of unique or I think important is that the ducts are very well circumscribed. So that's why this is in situ. Everything seems to be very tightly packed but neatly organized. And so this qualifies as ductal carcinoma in situ. What is important, though, is that patients who have DCS, in other organ systems, if one has an in situ lesion, we tend to think of that as a good thing. It turns out that in the breast, ductal carcinoma in situ, those patients, that is considered a precursor for invasive breast cancer. And so very often those patients are going to go back for surgery and they're going to do a wider excision. Number one, to be certain that there's no invasive component that had been missed as a result of sampling. These are images of lobular in situ and ductal carcinoma in situ side by side so that you can see how they appear differently. And as I mentioned, lobular lesions are often multifocal. So that is an important distinction between the two. So invasive ductal carcinoma is the most common type of the two, and the one that we probably encounter in the laboratory most often. So how do we work up breast cancer patients? Well, if a woman finds a lump in her breast, the very first thing after the physician has done his breast exam, patient may be referred for a core biopsy to the radiology department. And the core biopsy is typically going to be followed with either a lumpectomy or a mastectomy if, in fact, that core is cancer. We, of course, want to know if the patient has localized disease, as I mentioned earlier, or whether she has regional disease or metastatic disease. So our focus with that patient is going to be to make those determinations. So the tumor is going to be worked up for hormone receptor status, and we're going to talk about that in a moment. It's going to be worked up for HER2 status because now we have an opportunity with Herceptin. That is a mode of treatment that is afforded to women who are HER2 positive. We may be interested in the patient's tumor's proliferation rate, and we have markers that we use in the laboratory to assess that. And now we have techniques available to us to assess a patient's risk of recurrence. You may be familiar with the term triple-negative patients, and these are patients that are negative for estrogen receptor proteins, progesterone receptor proteins, and also negative for HER2. And that is particularly troubling because that means that that patient would not benefit from hormone blocking therapy or from Herceptin therapy. That means that the oncologist has fewer tools to try to manage that patient's illness. Some of you in the audience may have had the opportunity to attend the NSH conference in August. One of the keynote speakers, Dr. Anna Barker from the NIH, shared some very troubling information that I want to just make you aware of. And that is, she claims that tumor-banked samples, those are samples that you may be collecting and making available within your own laboratory, are often not suitable or the results achieved from those tumor bank samples are up to 80% of the time not reproducible. And that was very shocking to me because these are the very same samples that we are basing clinical decisions on. So there's an implication that if the tumor bank samples are not adequate for research or for developing treatment modalities, then how are they suitable for making clinical decisions on how to manage the patients? I asked her the question, are patients who are labeled triple negative, are they truly triple negative, or does this mean that that patient's sample was not handled properly in the OR or in the laboratory that led to these markers being negative when they might have otherwise been positive? And so it was a very troubling presentation to experience from that standpoint, because we go to work each day believing that we're doing our best for our patients, and yet there may be opportunities for us to do a better job with the samples that we receive. So for treatment options, the lesion is always going to be removed surgically, and whether that's done by lumpectomy or mastectomy, and very often that's a choice made by the patient. Often the surgical site is going to be radiated following lumpectomy, or they may even radiate the axilla. And if a patient is positive for estrogen and progesterone receptor proteins, then she will be a candidate for hormone therapy. Of course, chemotherapy is an option, but it's usually an option that we try to reserve for late in the disease, especially if a patient were to have metastatic disease later on or recurrence. Today we have opportunities for targeted therapy. So I mentioned Herceptin to you, and you're well familiar with doing HER2/neu testing in your laboratory. And then we have things like tyrosine kinase inhibitors and monoclonal antibody therapies that are available to some breast cancer patients. For the triple negative patients, often chemotherapy is going to be their only option, which severely limits the oncologist's tools for helping that patient. What are the challenges that we face in the laboratory? Well, one of the things that we have to be exquisitely aware of, and if you're not tracking this, then I hope that you will begin doing so, is something called cold ischemic time. I'm going to mention the CAP-ASCO papers a little bit later in this presentation, and if you've not obtained those documents, then I would encourage you to do so, because they contain a great deal of information. But there are two terms that we should be aware of, and one is called warm ischemic time, which I did not put on the slide because you and I have no control over that. That is the time that the surgeon clamps off the blood supply to where the lesion is located in the breast and excises the lesion. So from the time of clamping off the blood supply until the lesion is excised is defined as the warm ischemic time. The cold ischemic time is the time from excision until the time that we place the sample into fixative. And there is a strong belief that it is essential for us to keep that interval, the time from excision until the time of fixation, to as short an interval as possible. We also want to be aware of how long our tissues are in formalin, because as you know, we are now required to fix breast samples no less than 6 hours in 10% formalin, and we're asked not to fix them for longer than 72 hours in formalin. Now, in the earlier CAP-ASCO guidelines, initially when they first came out, we were told that breast tissues could fix no longer than 48 hours, which created some challenges for laboratories that are closed on the weekends, because there was lots of discussion on HistoNet about how do we adhere to the 48-hour maximum if the laboratory is closed for the weekend. And I know individuals tried to be somewhat creative in how they approach that. But now, with the latest guidelines, the latest HER2 guidelines came out in the fall of 2013. Now HER2 is permitted to be tested on tissues that have been fixed up to 72 hours in formalin. So this simplifies things somewhat for those of us in the laboratory. Grossing breast tissue will continue to be a challenge. There are a number of companies, Sakura certainly is one, that markets grossing tools that help the individual at the grossing table to cut relatively thin sections of breast tissue from lumpectomy or mastectomy samples. But yet, I would ask you to think about, is 6 hours of formalin really sufficient for something larger than a needle core biopsy. And I'm somewhat skeptical about that, but of course these are the guidelines that we've been provided that we're expected to adhere to. I believe that adequate fixation is absolutely key to ensuring that the prognostic marker staining, both ER and PR and HER2, if we are hoping to get accurate results from that staining, then we have to be certain that the tissues are well fixed. So what I'm showing you here, a couple of different things. The illustration in the upper left is an illustration or a drawing of a cell membrane. And without getting into much detail, what I want you to understand is that there are lots of things that that kind of hang off the cell membrane on the outside of the cell, and many of them will also cross through the membrane, and I have a better image of that in the next slide, and they end up in the cytoplasm. So something that binds to its receptor out on the membrane will create a chemical signal in the cytoplasm of the cell that will be detected by the nucleus. So you can see in the illustration on the lower right that if that yellow material on the outside of the cell was estrogen, the hormone estrogen, and it was binding to its receptor on the cell membrane, the very nature of the binding of the hormone to its receptor creates a series of chemical events in the cell cytoplasm that signal to the nucleus that something has happened on the membrane. We call that signal transduction. So this is a bit more complex illustration or drawing of structures on the cell membrane, and you can see that many of them actually cross through the membrane and into the cytoplasm. And so one of the things that I do want to stress in terms of fixation is that in order for us to get accurate staining results with ER and PR and HER2, then we have an obligation to be certain that all of these structures on the cell membrane are well preserved. If they're not preserved, then we can't expect to be getting accurate staining results. This is just an illustration of estrogen receptor staining with immunohistochemistry. And I know that this is a technique that is familiar to most of you. Virtually all cases of ductal carcinoma in situ are strongly ER estrogen receptor positive, which, as I've already mentioned, offers a very important treatment option for preventing progression to metastatic disease. So patients with DCIS are going to be offered hormone therapy if, in fact, they are positive, because that can be a very important tool for preventing them from progressing to metastatic disease. Now, Herceptin is one of the first drugs out there that requires an immunohistochemical or molecular test to be performed before it can even be offered to the patient. So the work that we do in our laboratories to demonstrate whether a patient is HER2 positive or negative is absolutely key to whether or not this therapy will be made available to that patient. The typical routine is that laboratories will do HER2 staining by IHC, and if the patient is positive, then this therapy can be made available. I have a colleague that I work with here in my department who has known metastatic disease. She has lesions in her liver. She has a mass in her opposite axilla, but she is being kept in her lesions are being kept at bay because she receives regular infusions of Herceptin, which is a very, very expensive therapeutic regimen. Now, the difficulty becomes when pathologists have difficulty discerning whether a patient is positive or not. Negatives are easy, and patients that are positive, like the image I provided on the screen, those are easy to interpret, and those are no-brainers. But it's those equivocal +1 lesions that cause some heartburn for the pathologist, because it's unclear whether or not those patients are truly positive, or maybe they're negative, depending on the assay you perform in your laboratory. And we don't want to offer therapies to patients that they're not going to benefit. So anywhere from 10 to 40% of breast cancers overexpress this HER2 receptor on their membranes, and the patients therefore would receive this Herceptin therapy. But I mentioned the breast cancer genes 1 and 2 and the triple negative patients. Those are individuals that will not benefit from Herceptin therapy and therefore would not be offered that treatment. This is a pic from a mastectomy specimen. One of the very first mastectomies that I saw early in my career left a very lasting impression, because I began working in the field when oncologists were still performing radical mastectomies, which were just I won't take the time to describe it for you, but the disfigurement to the patient and, of course, the debilitating results of such extensive surgery certainly was very difficult for the patient to recover from and to regain any sense of normal function. What I'm showing you here, though, is in the bottom of this image, you may recognize that that is skeletal muscle. And while we don't do radical mastectomies any longer, this particular patient, and the arrows are pointing to, this patient's breast cancer did extend into the chest wall muscle. And so it did become necessary for the surgeon to do that wide an excision on this particular patient. But this is not the norm. Typically today patients are offered simple or modified mastectomy, and many patients opt only for a lumpectomy. Now, this obviously is an extreme lesion that you see in this gross photograph. This is an invasive ductal carcinoma, and of course this is an example of what we don't want you to do. We don't want patients to wait to this extent before they have sought treatment. Regardless of the histologic subtype, the prognosis of infiltrating or invasive ductal carcinoma really depends on tumor size, as well as the presence of cancer in the nodes, the histologic grade, whether or not there's vascular invasion, whether or not hormone receptors are being expressed, and so on. All of those things play into the therapeutic regimens made available to these patients. 15 to 20% of patients that are diagnosed with ductal carcinoma in situ on a core biopsy actually do have invasive disease that was missed by the needle. And this is the reason why the surgeon has to go back and do a wider excision on those patients. Now, let me talk a little bit about mammography before we move on to more laboratory-related matters. Mammograms became available in 1969, and prior to that time, breast cancer lesions were always presented as palpable masses, in some cases very large masses. So back then, the diagnosis of carcinoma in situ was very uncommon. As you can see here, only 5% of those cases were diagnosed as carcinoma in situ. They simply were much more advanced by the time they became known to the patient and by extension to her physician. Today, with mammography, 30 to 50% of cancers are detected in the carcinoma in situ range. So clearly we are detecting lesions earlier, and that's a good thing. I think mammography has certainly proven itself to be an effective screening tool. What is disheartening is that only about 60% of women have mammograms. And if you're a woman in the audience who is eligible for a mammogram, if you're age 40 or above, I would strongly urge you to get regular mammograms and to not forego this very important screening tool. The median age of patients diagnosed with carcinoma in situ today is 10 years younger than women with invasive carcinoma, and I think that really underscores the significance and the importance of this tool. In this radiograph, I want you to look at the lower right portion of the image of breast, and you'll see a little yellow circle. This is a ductal carcinoma that was measured to be 0.7 centimeters, so less than 1 centimeter in diameter, that was detected on mammogram, and this patient was diagnosed as stage 1. This lesion would have been much too small to palpate, and had this woman not gone for mammogram, this lesion would have been undetected and continued to grow. So the patient was treated solely with a lumpectomy, and her 5-year survival rate was 95%, a very excellent prognosis due to the fact that she was very vigilant in getting her annual screening. So in this particular case, no chemo would have been necessary for this patient. Unfortunately, the converse is also true. This is a patient who, and I will tell you that without getting into politics, some insurance companies, and I believe Medicare is also doing this, the feds are recommending mammogram begin at age 50. This is a patient who waited until age 50 to have her screening mammogram, and the lesion that you see in the center of that image is 2.7 centimeters, and she was stage 4. So this is equivalent to what my friend Rosemary experienced. So if you are at age 40 or above and you have not had a screening mammogram, even if your insurance company is not willing to fund that for you, I would strongly urge you to get that procedure done. So you can come back to this on your own after the presentation is posted. I don't want to spend a lot of time with this, but I do want to point out to you that when you look at the number of people that have had mammograms within the past year, it's only around 51%. And some women opt to do mammograms every other year, and that's only around 66%. So there's a very large percentage of women that are not pursuing. Now, certainly we understand that some of these women do not have health insurance coverage, but even those who do have the coverage, the numbers that are getting screened are not high enough given the morbidity of this disease. So breast tumor behavior assessment rests largely on 3 parameters: tumor size, lymph node status, and histologic grade, which we've already talked about. What's interesting is that histologic grading, that is, done by a microscope by a pathologist on an H&E, really compares very favorably to the molecular profiling that we are able to do today. What is potentially problematic, though, is that if we were to have 20 pathologists in a room and we were to pass a case around to all of them, their agreement on the staging for that lesion would only be as good as maybe 65%. So that implies that your staging is very subjective, and therefore the molecular profiling that's available today is a tremendous benefit to our patients. So in addition to tumor staging, we do sentinel lymph node biopsy to determine whether there's regional disease. We will stain for estrogen and progesterone receptor proteins with immunohistochemistry. We also will stain for HER2/neu. You might be asked to stain for Ki67, which is a proliferation marker. It's a marker that demonstrates whether or not a patient's breast cancer cells have entered the cell cycle, which leads to mitosis or cell division. P53 is an important suppressor gene, tumor suppressor gene. You might be asked to stain for the P53 protein, which is a protein product of that gene. And the absence of that gene would imply that the P53 gene has been turned off. And that has dire consequences for progression of the disease. Today we can offer patients something called gene expression profiling, and the jury is somewhat out on this technology because it's rather expensive and represents an out-of-pocket expense for the patient. And oncologists aren't really clear on what to do with the data that's coming out of this testing. So your laboratory may be sending off breast lesions for Oncotype DX or PAM50 or whatever laboratory you may be using. If you had the opportunity, the CAP Today, I think it was in March, had a really excellent article that talks somewhat about this because this is the latest and greatest marketing for breast cancer patients, but oncologists are really unsure of what the information that comes from this testing really means for the patient and for therapeutic regimens. So you're familiar with the sentinel lymph node biopsy. The physician is going to inject a dye in the site where the original lumpectomy was performed, and after a period of time, that dye will migrate to the axillary lymph nodes. And so when they go to excise those lymph nodes, the blue dye makes it easy for the surgeon to find those nodes and to limit the excision to only those nodes. In the old days, they would perform what was called an axillary dissection, and so all of the lymph nodes would be removed from the axilla, which has a great deal of morbidity associated with it because, well, without getting into a lot of detail, patients would suffer from the effects of having their lymph nodes removed from that axillary area. Molecular markers include the things we've already talked about, and you are well familiar now with the significance of those markers, and you probably perform them routinely in your laboratory. In the old days, before the advent of estrogen-blocking drugs like tamoxifen, patients would undergo removal of their adrenal glands, of their ovaries, and of their pituitary gland in the hopes of limiting or preventing the production of estrogen as a means for controlling tumor growth. And you can imagine having to undergo that extensive surgery after already having undergone a radical mastectomy to remove the cancer. So we're fortunate that women today have the availability of pharmacologic agents to perform this estrogen blocking. I do want to repeat something I said earlier. If you have lots of adipose tissue, then your body has the potential to make a great deal of estrogen outside of the glands that you see in this illustration. So what are important caveats? We've talked about cold ischemic time. I don't think there's any question that if we allow tissues to sit outside the body and not having been placed in fixative, that we may be jeopardizing the staining results that we will get in our laboratories. The duration of fixation time is important. We track formalin in time and out time, not on only breast tissue, but on all of our tissues, because I believe that eventually the regulations will catch up and we will be asked to do that. If we do this for breast, why not for all tumors? Tissue processing. Your processing schedule may very well be different than mine. And anyone who works with breast tissue knows that if the tissues are cut in too thick at the grossing table, then our ability to get good tissue processing is going to be challenged in the laboratory. And some of you may be familiar with cutting blocks that did not process very well. Maybe you've floated out sections on the water bath and they've dispersed and what we call exploded on the water bath. Many years ago, I had a pathologist, I couldn't get them to recognize that they needed to do a better job at the grossing table at my former employer. And he had the audacity to say to me that, I said, how are you signing these cases out when so much of the tissue is missing from the slide? And he said to me, I'm only responsible for what's on that slide. And I would beg to disagree. So if there's anyone in the audience who believes that, if you're turning in slides where half the section isn't even present, I think we owe it to the patient to do a much better job than that. And I hope that you don't share the sentiment of that pathologist. What he was saying to me was, I can't be sued if no other pathologist can see something that I can't see. That's not, I don't think that's a reason for somebody to be practicing medicine, and I would hope that we don't have many individuals who think that way. Antigen retrieval, we know if you're skilled in immunohistochemistry, we have techniques that will enable us to reveal epitopes that may have been masked by prolonged fixation in formalin. So we have these things that we have to consider in our laboratories when we are performing the ER-PR and HER2 staining. The Neil Goldstein paper was the seminal paper that eventually led to the CAP-ESCO guidelines. And basically the Goldstein group looked at what fixation times were necessary to get consistent estrogen receptor staining using IHC. If you have the opportunity, I've given you the reference. I would recommend that you obtain this paper and you read it. It's actually a very good read. One of the things that they noted was that they were getting discrepant results between the ER staining they did on needle core biopsies and staining that was done on either the lumpectomy sample or the mastectomy sample that followed. They were not getting matching results. And that was really the work that led to the publications that are now known as the CAP-ASCO papers. So these have been updated over the years so that you can see the first HER2 guidelines came out in 2007. I believe the first ER-PR paper was in 2003. It was updated in 2010. And as I mentioned earlier, the most recent HER2 guidelines were published in, I believe, October of last year in 2013. So I've given you these in the presentation so that you can obtain these papers. Don't just go to the 2013 paper. There's a great deal of data in all 4 of those papers, and I would urge you to obtain them and to read them. What was, I think, of interest to histotechnologists was that by 2013, CAP was telling us that it was okay to fix breast tissues for up to 72 hours for both ER and PR and HER2, whereas prior to 2013, we were allowed to fix up to 72 hours for ER and PR, but only 48 hours for HER2, which really wasn't very helpful to those of us who were trying to manage our laboratories. Proliferation rate is often assessed using the IHC marker Ki67, and so you may be familiar with doing IHC staining with Ki67 in your laboratory. Patients that have tumors with high Ki67 expression are frequently offered chemotherapy because they have a very high mitotic rate and a very high proliferative rate. Those are essentially synonyms. Gene expression profiling, I've already mentioned. There are a number of laboratories offering this, and I don't think there's enough data assembled at this point for oncologists to understand how useful this information may be. HER2 is representative of an amplification on the chromosome 17, so you can see in the illustration in the upper left that when HER2 gene is amplified, which is illustrated with those black marks on that chromosome, then those patients, and that represents 20 to 30% of breast cancer patients, if they're amplified, then they are candidates for Herceptin therapy. In the lower image, you can see HER2 staining by IHC, and you can see various degrees of intensity of staining. So, of course, the very positive image on the right, no one would argue with, and the negative image in the upper left, you probably wouldn't argue with those. But the B and C images now are a bit more problematic. Are those patients, in fact, positive or not? This is just to show you that there's actually a HER2 family. This is the human epidermal growth factor receptor on the membrane of cells, and there are different ones, HER2, HER3, HER4, and so on. And Herceptin is an antibody that will bind to those receptors. And by doing that binding, it inhibits mitosis of the cell and also induces apoptosis of the cell. So as I said, I have a work colleague whose tumors are being managed, and she's been on Herceptin for about a year, I believe. I think she gets infused every other week, if I'm not mistaken. You can get this from the CAP-ASCO paper. I'm not going to spend any time as our time is running out. I probably need to draw this to a close, but these are the many different things that are believed to affect the HER2 results that your laboratory is issuing. And so CAP and ASCO want us to be aware of this. The latest paper spends a great deal of time advising pathologists on how to interpret the HER2 staining results. I'm going to flip through these slides very quickly. I do want to mention this is just an illustration so that you can see how tissue sections look based on the amount of time that they've had in formalin. So in this illustration, if CAP is telling us that 6 hours is the bare minimum, you can see that if we can go more than 6, the images look better even without a microscope. So I would argue that one's likelihood of getting accurate IHC staining for ER, PR, and HER2 are going to be increased as one extends the time in formalin.
Thank you so much, Vinny. We do appreciate your time this morning, and that was a very thorough presentation. I do have one question that came in. Since it's only one, I'm going to go ahead and ask it. For those of you who can't stay on any longer because we have run out of time, I do apologize, but if you can, please stay on to listen to the answer to this question. It says, let me just open it up a little bit more here. When you receive a tumor mastectomy specimen in formalin, do you ask the pathologist to slice through the specimen to allow for better fixation deeper in the tumor without potentially compromising the margins?
So I'm not sure my example is going to fit that scenario. We do not receive mastectomy specimens in formalin. We insist on them coming to the laboratory fresh, and our hope, we certainly encourage the OR to get them to us quickly. They are hand-carried. I have no way to know if they sit in the OR. I hope that they don't. But we do bread loaf our mastectomy specimens before we place them into formalin, and that is absolutely essential. Before a patient has had a mastectomy, that patient would have had a lumpectomy. So with the mastectomy samples, one of the things that we have to identify, not only the surgical margin of the mastectomy itself, but also we want to see how far the lesion may have extended from the site where the original lumpectomy was performed. We have in our laboratory a Faxitron X-ray machine that really helps to guide the diagnosis, the dissection of the sample. But we do exactly what you're proposing in your question, and that is to make certain that the sample is bread loaf to allow adequate penetration of formalin. To place a mastectomy sample into formalin without doing that bread loafing, and the recommendation is that it be sliced every 10 millimeters, or which is 1 centimeter. So sometimes people will bread loaf them but not make those slices thin enough. So I did want to add that to the answer. I hope that's of some help, but we don't get them in formalin.